What's up, you guys? Welcome back to From the Ground Up. Today, I am going to take you guys on a deep dive into some biomechanical principles of the pelvis itself. So in the last few episodes, we've looked at why Kegels are just not it. We've talked about the foot and its connection to the pelvis. And we've talked about some rib cage and pressure management principles. And so today we are really going to look at the pelvis itself, the hub of all things pelvic floor and dysfunction and function and what that actually means to me. So pelvic floor muscles are meant to be automatic. They're meant to act responsively to pressure changes and to load that is placed on the pelvis and the pelvic floor. They're meant to anticipate our movements. And in order for the pelvic floor to be able to do that, to be able to function automatically and to respond to load and to anticipate what we're about to do, they have to have an optimal length tension relationship, just like any other muscle or muscle group in the human body. And this length tension relationship, this ability to function optimally, depends heavily on the biomechanics of the pelvis itself, meaning what are the bones doing? What position are the joints in? What does movement look like there? Okay, so true pelvic biomechanics is what will allow the pelvic floor muscles to have an optimized length tension relationship to do their job. So let's work through what that means. To start, we have to have ilium internal rotation if we want the pelvic floor to have a chance, even just have a chance at doing its job, at working well. This is especially true when we're looking at load or during impact, force absorption, things like that. So we have to have this ilium internal rotation to even talk about the pelvic floor having an optimized length tension relationship. So let me explain what ilium internal rotation is, because I remember whenever I first learned this, I was like, what do you mean the pelvis can rotate and what does that look like? And I remember my brain having a hard time kind of grasping what that actually meant and what it is and what that looks like functionally, right? I actually had a patient the other day, I was talking a little bit about pelvic rotation, and she was like, well, how the heck do I make it do that? And I was like, I got you, girl. Don't worry. I'm going to show you. We're going to go down that path. So I'm going to take you there too, because this used to be hard for me to visualize as well. So when we're talking about ilium internal rotation, okay, I'm literally talking about the ilium bones going into kind of this coupled three-dimensional movement, okay? So you picture the ilium bones, our big butterfly bones of the pelvis. Ilium internal rotation includes a coupled motion of posterior rotation of the iliums, okay? So they're rotating on that axis posteriorly. At the same time, the hip is going into extension. That is what happens when we have ilium posterior rotation. And we are seeing kind of this outlet, so the outlet of the pelvis at the bottom, we're seeing this opening of the pelvic outlet, which, by the way, is also technically adduction, because if you think of a femur remaining fixed and then the ilium bone starts to widen at the outlet, that ilium bone is actually moving closer to the fixed femur bone. So it's technically called adduction, right? Because that angle between the ilium and the femur is getting smaller. We are adducting it. And we are also seeing a relative sacral nutation. And if you're anything like me, I, for the longest time, didn't know what nutation and counter-nutation was. I literally think back to PT school, and I think back to whenever I was learning this in my, I guess, a biomechanics course or anatomy, whatever, wherever I was learning about nutation and counter-nutation. I vividly remember my professor saying, oh, this is a confusing principle. Don't worry if you don't get it. I don't get it either. It won't be on the test. That literally has stuck with me forever. And the story I've told myself is I don't need to know what nutation and counter-nutation mean. And so I carried that with me for the longest time, and I just blocked it out in my brain. And then finally, as I'm going into this deep dive as a pelvic floor physical therapist, I had to confront my fear and I had to learn what nutation and counter-nutation mean. So let me explain. So sacral nutation is essentially the entirety of the sacrum going into flexion. You can imagine it happens with lumbar extension, lumbar lordosis. They kind of happen together. So the top part, this is also confusing, which is also known as the base of the sacrum. The top part superior portion of the sacrum tips anteriorly, okay? And that means the bottom part, the apex, also known as where, the tailbone and coccyx attach, goes posteriorly, kind of goes backwards, right? So that's nutation. The entirety of the sacrum tips anteriorly, okay, towards the front, which means counter-nutation is just the opposite. It tips back to where it was to start, or maybe a little bit further back. The tailbone tucks under, right? So that's nutation and counter-nutation. And again, this took me years and years and years to actually solidify in my brain. And if you guys want me to tell you how I remember it, don't judge me. This is kind of embarrassing, but the way I remember it is sacral nutation starts with an N, which means it moves towards the nuts, which is so funny because I'm like, I don't even treat males, but it helps you remember it. So maybe it'll help you too, because nutation, sacrum is moving anteriorly or towards the nuts if someone were to have nuts. Okay, so that's how I remember it. Let's get back on track to talking about ilium internal rotation. Let me recap. So ilium internal rotation is the ilium bones going into this posterior rotation, as well as the outlet moving into adduction or widening. The pelvic outlet is getting bigger as the iliums internally rotate, okay? And you can imagine those iliums, in order to do both of those things, in order for the outlet to widen and the iliums to rotate posteriorly or backwards, that is a relative internal rotation. Just imagine, like, you can kind of do it with your hands, or if you have a pelvis model, you can kind of look at that and imagine that. That is ilium internal rotation. If the sacrum is not moving, that relative to the sacrum means the sacrum is more nutated, okay? And this has confused me in the past too, because in my head, I'm picturing the iliums are moving. And in my head, I'm like, well, if the sacrum's not moving, if the sacrum is fixed, because we're talking about ilium rotation, how is the sacrum nutating? And it's because it's a relative motion, okay? Even if the sacrum remains fixed and we're talking about iliums moving and a sacrum that's not moving, the way that the iliums move in relation to the sacrum means that it is relatively nutated, okay? I know that that is confusing. I really encourage you, if you have a movable pelvis model, I really encourage you to play around with this and kind of look at, okay, if I take the iliums into this posterior rotation and I open the outlet, I widen the outlet, and I leave the sacrum alone, you can imagine that sacrum bone is now going to be more nutated, okay? The base is more towards the nuts, okay? So that is ilium internal rotation. And I wanted to spend a lot of time describing this because ilium internal rotation is the key to life. Okay, maybe not that. Maybe don't go that far. But ilium internal rotation is the key to setting the pelvic floor muscles up for optimal length tension relationship, for their ability to work automatically, to anticipate movement and respond to movement and do their job, okay? Especially without our patients having to think about it. So we have to ensure our patients' iliums can go into this ilium internal rotation. If they are able to do that, so if the iliums internally rotate, that means the outlet widens, all of the pelvic floor muscles that attach in and around the pelvic outlet are going to be more pulled taut. And that motion, when the outlet opens and widens and those pelvic floor muscles get more pulled taut or tensioned eccentrically, is what's going to allow the pelvic floor muscles to kind of boing back up into the pelvis and lift the pelvic organs, support the pelvic organs. And it's going to optimize the anterior pelvic floor muscles to be able to control the urethra and keep pee in and support the bladder and all of those good things that we need to have to not feel prolapse symptoms and to not pee our pants. Okay, stay with me here. We're gonna kind of move past this in a minute, but we're gonna come back to it. But essentially, we have got to make sure our patient's pelvis has the ability to go into ilium internal rotation. Alrighty, that's going to be like paramount, and we are going to talk about how we can do that functionally and all the things. But bottom line, we have to make sure the patient's ilium can do that. Now, if that's ilium internal rotation, let me just kind of reverse it so you can have a good mental picture of ilium external rotation before we move on to my next kind of main idea. So if ilium internal rotation is posterior rotation of the ilium and outlet adduction or widening, space getting bigger, then ilium external rotation is going to be the opposite. We are going to have more of an anterior rotation of the ilium, and we are going to have the outlet that kind of abducts or gets smaller. So abducts meaning moves away from the fixed femur bone, gets smaller. And by extension of that, if the outlet of the pelvis is closing, shrinking, getting smaller, that means any and all muscles that attach to it, aka the pelvic floor muscles, are going to be put on more of a slack. They're going to be more descended. They're going to be more sensitive to that downward pressure. So we need the ilium to be able to do both, but in an ideal world, it really, really needs to be able to go into that internal rotation to allow the pelvic floor muscles to eccentrically lengthen, boing back up, support the organs, clamp off the urethra, all of that beautiful stuff that we've talked about so far that needs to happen to keep our patients dry and keep their organs supported, okay? Let's move on, because now that I've potentially blown your minds with ilium relative motion and nutation and counter-nutation of the sacrum, feel free, by the way, to rewind this and go and listen to that section again, because I know it can be so confusing, especially if this is the first time you're hearing these concepts. Like, literally, I'm telling you the truth right now, this has taken me years to feel like it's like fully grasped in my brain, okay? That's ilium rotation, namely internal rotation. We need internal rotation for optimal length tension relationship of the pelvic floor muscles. Let's move on, because ilium rotation and then what we know as pelvic orientation are not necessarily the same thing. You can have ilium internal rotation and ilium external rotation, and you can have pelvis, entire pelvis, being into an anterior orientation or a posterior orientation. And they can happen together or separate. You can have an ilium that is internally rotated and the entire pelvis is anteriorly oriented. Okay, you can have any combination of those. You can have an externally oriented ilium with an anteriorly oriented pelvis. And those are all really big, confusing words. So don't feel like you have to understand or grasp in this very moment of time all of those options. Just what I want you to take away from kind of this idea is that the iliums themselves can rotate anteriorly, posteriorly, independent and not related to necessarily the entire pelvis going into, anterior orientation, which is also like anterior pelvic tilt, posterior pelvic tilt, which is also posterior orientation, okay? When I say pelvic orientation, most people refer to that as anterior pelvic tilt, posterior pelvic tilt. I prefer the term orientation because I just think of it as the entirety of the pelvis just kind of oriented more anteriorly or more posteriorly, okay? So you can have ilium IR and or ER with anterior orientation or posterior orientation, and they can be independent of each other. That's the bottom line of this point, okay? So if ilium rotation is the ilium moving alone in relation to the sacrum, so the sacrum can be fixed and then the ilium can rotate around it. So the ilium can do that with regards to what the sacrum is doing. They can move independently of each other. And then when we talk about pelvis orientation, that is actually the sacrum and the ilium moving with each other, okay? So the entire pelvis, that's what helps me remember this, is I'm like, anterior orientation of a pelvis means the block that is a pelvis, the iliums and the sacrum both together orient themselves or tilt anteriorly. For posterior orientation, the sacrum and the iliums together, both, all three at the same time, orient themselves into a more posterior tilt. Okay, so that's kind of how you can think of pelvic orientation or tilt, if you prefer that term. The sacrum and the iliums are moving together in the same way. Versus ilium rotation, we're talking about more relative motion. So the iliums, what are they doing without regard to the sacrum? They're moving in different dimensions by themselves, okay? So it's important to note, if you guys think back to where I was describing ilium internal rotation, this is where I might break your brain, so stay with me. In regards to ilium internal rotation, meaning the ilium relative to the sacrum is going into posterior ilium rotation and outlet widening, that can happen at the same time that the entire pelvis orients itself anteriorly. And now you're like, Becky, you said ilium internal rotation includes posterior rotation of the ilium. Yes, relative to the sacrum, Okay, this is the part that has taken me a long time to grasp. So that's why I'm hammering this and saying this in 9 different ways for you guys, because it has changed the way I treat the pelvic floor. So stay with me. I'm going to say it all again for you. Yes, ilium internal rotation, which is necessary for optimal pelvic floor function. That includes ilium posterior rotation in order to get internal rotation. However, that can happen. So the ilium can posteriorly rotate in relation to the sacrum. That can happen while the entire pelvis, the ilium and the sacrum together, also tilt or orient themselves anteriorly. Hopefully that's starting to click for you. And if it's not, again, rewind, listen again, because this is a confusing concept. I just want to acknowledge that because this is confusing, especially if it's the first time you're hearing it. Still thinking about pelvic orientation, which is iliums and sacrum orienting themselves, tilting themselves together anteriorly or posteriorly, okay? Human beings in general are biased to be more anteriorly oriented, okay? This has to do with plenty of factors. A lot of it is due to our organ placement, how we breathe, movement patterns, the fact that we sit all day long, all of these things. But there's lots and lots of reasons of why human beings tend to be biased more into an anterior orientation of the pelvis. And that is not a bad thing. I am not here to villainize anterior pelvic tilt, but just understand that in general, you are going to find the vast majority of your patients are going to be more anteriorly oriented. Again, their iliums can do different things, even though they're anteriorly oriented, okay? However, the degree of that orientation, the degree of which a human or one of your patients is tilted into anterior tilt or anterior orientation is going to vary, right? You've had patients that you're like, oh my gosh, their lumbar lordosis is huge, like their pelvis is just dumped forward, all the things. And then you've had patients that seem to have more of like a straight lumbar spine, just a straight spine in general, and maybe they shift their weight forward. Chances are they are still technically, from a biomechanical perspective, in an anterior pelvic tilt. Even if they're a glute clincher, even if their lumbar spine is more flat, the vast majority of people still are in some degree of anterior orientation. Again, that's not a bad thing. That's just our bias as a human being and how we move and how we're made and how our organs are and how we breathe and all the things. Okay, it's not bad. The goal is not to get our patients out of this anterior pelvic tilt or anterior pelvic orientation. The goal is to create a biomechanical environment, okay? Biomechanical meaning how the bones move, how the joints move. The goal is to create a biomechanical environment where the pelvis can move in and out of both anterior pelvic tilt and posterior pelvic tilt. So we need our patients to be able to go in and out of anterior and posterior pelvic tilt. Okay, that's the goal. The goal is not to get out of anterior pelvic tilt because it's bad. Okay, it's not bad. We have to be able to get our patients to move either way. We also need to ensure our patients can move their iliums in and out of internal ilium and external ilium rotation. Okay, again, the goal is not only get internal rotation, even though I'm hounding on the importance of IR. The goal is that they can do both, okay? And then the goal, third part, is that the sacrum can move in and out of nutation and counter-nutation. We don't want them only nutated. We don't want them only counter-nutated. We want them to be able to move in and out of either one functionally as needed to allow the pelvic floor to have optimized link-tension relationship to be able to function automatically. The key is that all of these motions, pelvic orientation, ilium rotation relative to the sacrum, sacrum nutation and counter-nutation relative to the iliums, the key is that all of those motions happen functionally as a part of the whole biomechanical chain, which we know is influenced from pressures above and kind of force absorption biomechanics from the ground up. So that's the ultimate goal, is to have a pelvis that can move in and out of all of these planes of motion, okay? So now that we understand that ilium rotation means ilium movement independent of the sacrum, independent of counter-nutation and nutation, relative to where the sacrum is in space. That's ilium rotation, internal and external. And now that we also know that pelvic orientation is more of the concept of the entire pelvis, so the iliums and the sacrum together orienting itself more anteriorly or more posteriorly, regardless of what rotation the iliums are in. Okay, those are two separate things that can happen separate of each other. Now that we know kind of the ideas of both of those things, I want to tell you what your secret weapon is for training a functional pelvic floor. And I'm going to give a quick shout out to my guy, Steve D. He is the guy who has coined this term, pelvic pronation. Okay, and I love it. I use this term all the time. I use this term in my course. My students who have gone through my entire course use the term pelvic pronation. And so I want to explain to you what this is and why it's helpful. So when we're looking at pelvic pronation, this is another coupled movement, okay? So defining pelvic pronation, this is the idea of a pelvis moving on a fixed femur rather than a femur moving inside of a fixed pelvis. Okay, so think hinge, pelvis moves on a fixed femur rather than clamshell. Clamshell is a femur rotating inside of a fixed pelvis. The way I think of this, the way I picture this is the ilium / pelvis of a stance leg. So imagine yourself standing on your right leg. We'll just take the right leg for an example. The ilium and pelvis of that right stance leg moves into flexion, adduction, and internal rotation. And if you're an orthopedic PT like I am, in your brain, you're thinking, that's an FAI. Yes, it is. This is a combined movement of flexion, adduction, and internal rotation. The pelvis as a whole, okay, we're going to talk orientation. The pelvis as a whole orients anteriorly into flexion, okay, anterior pelvic tilt. The ischium adducts in relation to the femur. It gets closer to the femur, to the fixed femur, so the pelvic outlet opens. So we have adduction, and the ilium internally rotates around a fixed femoral head. So that's what I'm talking about when I say flexion, adduction, and internal rotation. We have a pelvis that goes into flexion, which is anterior pelvic tilt on top of a fixed femur. We have an ischium that is adducting in relation to the fixed femur, which is essentially just the pelvic outlet opening, widening. And then we have the ilium, which is internally rotating around the fixed femoral head, which is including that ischium adduction. And then we're getting a little ilium posterior rotation as we move into pelvis anterior orientation, because remember, they can happen independent of each other. That is the entire idea of pelvic pronation. You see this functionally in a lot of people. Okay, this is the typical model walk. This is the model walking down the runway, and they are getting that contralateral pelvic drop, Trendelenburg gait pattern, whatever you want to call it, and they're just like slunking down the catway, and they're just like, and their pelvis is just going to fall off of the femur. That is pelvic pronation. And for the longest time, we were taught in PT school, we're still taught a lot of times as PTs to this day, that is, quote, bad. Okay, that is FAI. We want to avoid that at all costs. We want to train that out of our patients. And I actually want to advocate that the key here is not actually working to train this FAI, this pelvic pronation, out of our patients altogether. We actually want to train the control of this range of motion in our patients, this eccentric control of the pelvis going into this pronation. This motion, this pelvic pronation, is what happens in single leg stance. So walking, running, landing on a single leg, cutting, pivoting. It is very functional and very appropriate. Okay, and so we do not want to train out this dropping, collapsing, we've called it, of the pelvis altogether. We simply want to train our patients to be able to eccentrically control the pelvis going into pronation. So that way it can control the amount, the extent of the pronation that's happening, okay? This is why traditional exercises like bridges, clamshells, monster walks, squat with a band around the knees to cue kind of that external rotation, that pressing out into the band, all of these things train away this pelvic pronation, right? We've all been taught this. Oh, you see Trendelenburg, you see contralateral pelvic drop, better throw them in some lateral monster walks, better give them some clamshells, better strengthen those external rotators, right? And the thought process there was close, not fully wrong. Yes, we need strong external rotators, but all of those things are focused more on the concentric activation of those hip external rotators, right? So pressing out into the band, stepping laterally side to side, going like lifting the leg into a clamshell, right? So all of these things are training, for the most part, more concentric strength of hip external rotators. And on top of that, more femur moving in pelvis external rotation, right? So clamshell, monster walk, we are taking a lateral step out. The pelvis is fixed, but the femur is stepping out, okay? So these more traditional exercises that we might be using to, quote, fix this pelvic pronation, this contralateral pelvic drop, just, quote, strengthen the glutes, strengthen the hips, they're actually training away this pelvic pronation rather than training control of it, okay? They cause femoral external rotation, which by extension is going to cause ilium external rotation. They work kind of together. Instead of allowing the ilium to internally rotate on the femur in a controlled manner, okay, via eccentric control from the hip external rotators. The key here is eccentric control of pelvic pronation in functional movement patterns. That's it. Okay, and how can we do this? We can use hamstrings, because hamstrings, they're going to eccentrically control for the flexion component, right? Think of a hinge. We go into a hinge motion. That is hip flexion. That is pelvis anteriorly orienting itself on top of a fixed femur, okay? And we have hamstrings that are eccentrically lengthening and controlling that forward motion of the pelvis, okay? So that is one way that we can eccentrically control a portion of pelvic pronation, is training eccentric hamstrings. We also want to control our hip abductor muscles and our hip external rotator muscles, okay? So these are our glutes. This is glute med, this is obturator internus, the piriformis, the deep hip external rotators. All of those lovely, juicy hip, quote, stabilizer, hip external rotator muscles do need to be strengthened. I'm not saying that they don't. I'm just saying clamshells and lateral band monster walks are not the way to do it. We need to actually strengthen them less concentrically and less with a femur moving inside a fixed pelvis and more with a fixed femur and allowing this eccentric lengthening or eccentric control of internal rotation on top of a fixed femur. And so that's really the key here, is understanding what pelvic pronation is. So it's FAI, it's flexion, internal rotation, and then it's adduction of the pelvis to the relative to the femur. And then instead of training it out of our patients and not allowing it to happen, it's training our patients to be able to control the extent of the pelvic pronation in functional movement patterns. If we can train our patients to control this pelvic pronation, it will allow the pelvic floor muscles to achieve that lengthening, because it's going to allow that outlet to widen, okay? It's going to allow that space to be created at the pelvis. So it's going to allow the pelvic floor muscles to get that length and reascension that comes with ilium internal rotation and adduction that we talked about at the beginning, pelvic outlet widening, okay? If we train our patients out of this, they will not be achieving ilium internal rotation that is so necessary for a functional pelvic floor. This is what will allow this eccentric control of pelvic pronation. This is what will allow the pelvic floor muscles to function automatically during load, during force absorption, AKA during life, simply by restoring the length-tension relationship of the pelvic floor muscles, okay? And so we do that by everything I just taught you guys, by optimizing the ilium's ability to rotate internally, externally, by optimizing the pelvis as a whole, so iliums and sacrum together, being able to orient itself anteriorly and posteriorly. And then finally, by understanding this concept of pelvic pronation, which is pelvis flexion or anterior orientation on a fixed leg with ilium internal rotation, okay, and then controlling that in an eccentric manner rather than training that out of our patients. If you can wrap your head around that and apply that to your patients, all of that entire concept is what is going to restore this length tension relationship of the pelvic floor muscles to allow it to function automatically as it was meant to function. Okay, so that's our whole goal. Now, you know me, and you know I always say let's zoom out of the pelvis, so I want to remind you, before I wrap up, I want to remind you that I just did a super, super in-depth dive into pelvis biomechanics and how we can apply that to patient treatment. It will not make a difference if we fix everything. We clean up all this biomechanics, all this range of motion. We have an ilium that's so beautifully internally rotating, and we have a hamstring that's so amazingly eccentrically controlling this this pelvis going into anterior orientation, right? We're doing all the things. We have eccentric hip external rotators that are really just lovely at controlling this internal rotation of the pelvis on top of the femur. We've done all that. None of it will matter if you are only looking at the pelvis. You will miss out on the things that are coming from the top down and the things that are coming from the ground up that are impacting from a functional life perspective, that are impacting the pelvis's ability to find and control the range of motion that you just worked so hard to create. Okay, let me say that again in a different way. If you work so hard in your treatment sessions to optimize, fix, whatever, the pelvis for your patients, and they have achieved the right amount of rotation, they have eccentric control of everything, and you're like clapping, you're so proud, you're like, wow, look at that hinge. I am telling you right now, if you have not also zoomed out and looked at rib cage's implications from the top down onto the ilium's ability to do those things, and from the ground up, how the foot and ankle is impacting the kinetic chain, which will allow or not allow the ilium to go into these ranges that we just talked about, your patients will not, like, their results will not last, okay? Because you didn't get to the thing that was messing up, for lack of a better term, messing up the pelvis biomechanics in the first place. This is why if you treat the pelvis in the clinic, then your patients get off the table or they get off the floor and they walk back into their lives, okay, their issues tend to come back maybe the next day, it might be a few weeks, it might be months, but they tend to come back. Be sure you can go back and listen to the last couple episodes if you missed them, for a more in-depth dive at the foot and the pelvic floor connection, where I kind of go into the kinetic chain there, as well as the rib cage and kind of how that impacts the pelvis and the biomechanics there, if you haven't listened to them already, because that will kind of help you put it all together. I just wanted to retouch on that because I know that I spent half an hour teaching you guys the pelvic biomechanics, but if you do not look from the top down and from the ground up, it's not going to stick and it's not going to last and none of it will matter anyway. You would have spent all this time learning about nutation and what that means, and it's not going to matter because your patients they're not going to stay better, okay? Let's bring it all home. If we want to restore that automatic function of the pelvic floor muscles, we have to restore the pelvic floor muscles' length tension relationship first. They have to even have the possibility to do their job automatically. And we do that by restoring biomechanics and functional biomechanics at the pelvis. We have to understand the difference between relative ilium motion, okay, so ilium internal rotation, ilium external rotation, relative to the sacrum, and then pelvis orientation. So this is anterior orientation, posterior orientation. This is ilium and sacrum orienting themselves together. We got to understand the difference of those two things. We have to understand that our patients need ilium internal rotation to be able to achieve that pelvic floor support and reascension. Okay, we've talked about that. We also need eccentric control of pelvis on femur movement. Okay, this is eccentric control of that pelvic pronation, that flexion, adduction, internal rotation that happens. Okay, we have to have eccentric control of that coupled movement, that entire pelvis moving into FAI essentially when we load a single leg. Like anywhere else in the body, we need both the range of motion capability and the control of that range of motion for adequate function. That is true for any single joint and any single body part in the entire human body. You have to have first the amount of range of motion, and then you have to be able to then control that range of motion eccentrically. And remember, the foot and rib cage are going to both heavily influence those pelvis biomechanics that we just talked about. As important as these pelvis concepts are, and as much as I love a good ilium internal rotation, you guys, you must zoom out and look above and below the pelvis from the ground up to ensure you have got the root cause of why the pelvic biomechanics were off in the first place. I cannot stress that enough. If this was helpful to you guys, I'm so glad. I know that this one was pretty dense, and I know it can be super confusing, so please feel free to go back and listen 10 more times if you need to be able to grasp it. Like I said, this has taken me years. But if you did find any of this helpful, I would love if you took a screenshot and shared it to your stories and tagged me. Send this to a fellow clinician that you think this would be so helpful for. Also, Shameless plug, you guys. We are coming up on the next cohort for fall 2025 of my signature course. Okay. It is launching to the waitlist September 2025. So if you're listening to this and it is not October yet, it is not too late. Please go join the cohort, the waitlist for the cohort of my course. You're going to love it. This is where I teach you everything I know about evaluating and assessing and treating the human body when it comes to pelvic floor dysfunction. We start at the initial evaluation. I turn everything you thought you knew on its head about evaluating the pelvic floor. Then we dive deep, one module at a time, into the pelvis, into the foot, into the rib cage, so you can truly understand those relationships and help your patients overcome their pelvic floor dysfunction for good, not just in the short term. And I even have a whole module in this course that covers holistic considerations of the pelvic floor, so that way you can get the full picture when you're treating. This is my favorite thing that I do, and I only open it a couple times a year. So please join the waitlist if you are at all interested. And thank you guys so much for being here. Thanks for putting your thinking caps on today. I know that this was dense, but I really appreciate your time. I will see you guys on the next episode. So let's change the game.